Good day, this is great surgeon. Today we're gonna talk about a very important critical chapter. It's the holy pathology. Pathology might seem at first in the beginning as a long chapter, but in fact, pathology isn't that long. It's a revision chapter for every general surgical specialty within your MRCS scope. And by the way, the MRCS is sufficient scope for MRCS exam. So let's crack this chapter together and divide the whole surgical specialties together within the pathology. Together we can, with the grace of God. A very famous question in the exam is about the ASA scoring, the American Society of Anesthesiologists Physical Status Scoring System. It's a pre-operative scoring system, very important in the exam, and might be asked directly to score the patient or the critical situation you can do for the patient. Like an old man patient, would you do for him an angioplasty or do a bypass surgery? And which type of bypass, femoral or aortobifemoral or axillofemoral, anatomical status? If he is ASA 5, you can't do for him an anatomical aortobifemoral bypass. Instead, you will go for extra anatomical like femoral if the other side is patent, or axillofemoral if the other side is affected as well. This is the important applied anatomy surgical applied information for the ASA scoring. The ASA grading is graded from 1 to 5, and you put a letter E for emergency. So the 1 is the best, 5 is the worst. 1, there is no organic or physiological biochemical psychiatric disturbance with this patient. He is a healthy one. The surgical pathology is localized and hasn't involved any systemic disturbance. In the grade 2 ASA grading, you will find a mild to moderate systemic disruption caused either by a surgical disease process or through underlying pre-existing disease. While the grade 3, there is a severe systemic disruption caused by either the surgical pathology or pre-existing disease. And take care, 4, where the patient has a severe systemic disease that has a constant threat to life, while in grade 5, a patient who is morbid and will not survive without the surgery. And the scenario within the exam, he will tell you an old patient like 60-year-old man admitted following a collapse while he waiting a bus, and the clinical examination confirmed a ruptured abdominal aortic aneurysm. This is the patient, he will not survive without a surgery. So this is ASA 5. While another patient who is young patient like 20-year-old man had a lipoma 4 centimeter, and he gone to the hospital to remove it as a day case. What is this scoring? There is nothing here. It's an ASA 1. Let's have a tricky one. A 70-year-old man due to undergo inguinal hernia, but he has COPD and has an exercise tolerance of 10 yards. He can't tolerate more than 10 yards. And he has a pitting edema to the thighs. This is an ASA 4. If he didn't do the hernia, it won't. He will survive anyway. But still, there is a threat to his life because he is morbid and he has inguinal hernia. So there is a severe systemic disease in nature and constant threat to life by obstruction or strangulation due to the inguinal hernia, with a COPD as well as the cardiac status where he has a pitting edema up to the side. So this is going to be with the ASA 4. There are some classifications that add ASA 6 where the ASA scoring 6 means this patient has been declared brain dead, whose organism is being removed for donor purposes. Dear great surgeon, you have to be familiar with the healing process of the soft tissue and the bone, starting from the skin, muscle and tendons, as well as the neurovascular bundle and the bone. Every healing process will be asked in like applied manner, like in the bone fracture. He might ask you about the healing process, starting from the bleeding vessel and the hematoma formation, as well as the periosteum, which contains the osteoblast, which produce the new bone, and the mesenchymal cells that produce cartilage, and the connective tissue with the hyaline cartilage that form the callus. He might ask you, when does the callus form and be visible radiologically? So the callus might be formed early, but to be seen within the radiological sign not before 3 weeks. This is called the applied pathology. So you are a surgeon, as an orthopedic or plastic surgeon or even general surgeon has to be familiar with the X-ray and know, is this patient had a recent fracture, and from when this fracture you see the X-ray, you can see the callus, so it's a recent, it's before 3 weeks. If you see the callus, so it's after 3 weeks. That's the applied pathology. Very important in your assessment of the healing process. And by the way, the periosteum is very important for the healing because it's contained the osteoblast and produce the new bone. But the periosteum itself can't be within the fracture site. It has to be retracted behind the fracture site, otherwise it can interfere with the healing process. Yes, it contains the osteoblast. Yes, it's important for the healing, but take care. There is no soft tissue can be within the fracture site, otherwise the body will deal with it as a foreign body. That's why we take the osteotome and retract the periosteum behind to make it able to creep again over the bone and make a healing process sufficient. So as the new bone approaches the new cartilage, the endochondral ossification occurs to the bridge of the gap and the trabecular bone formation, and the trabecular bone is resorbed by the osteoclast and replaced with compact bone. The factors that affect any wound healing regarding skin, bone, nerve, whatever it is, there are some general rules. The age, the nutrition, the bone disorders regarding the bone itself, if we are talking about the bone fracture, and systemic disorder like diabetes, morphine, Ehlers-Danlos, cause abnormal musculoskeletal healing. And Ehlers-Danlos has a very, very bad prognosis regarding the wounds. Take care. While the drugs like steroid intake or non-steroidal anti-inflammatory agent, if they are being intake, and regarding the bone itself, the type of bone which fracture, the cancellous bone, sponges bone, take care. All of those matter factor. And the degree of trauma, is it crushing injury or it's a simple injury, or the more extensive injury of the bone surrounding tissue, the poorer the outcome. Remember the Gastello classification. The vascular injury associated, remember again the Gastello classification, especially the femoral head and the talus and scaphoid bone, they are very liable to necrosis. Degree of immobilization, the intra-articular fracture, the separation of the bone end, the intervening by local, those were the general factor, and the local factor regarding the wound itself is very important. Keep in mind the general factor of the patient and the local factor of the wound. And of course, the iatrogenic factor by 2. Take care. Just like the bone injury matters to us, the nerve injury is very important. According to Sunderland's classification, we have 3 types of nerve injury: the neuropraxia, axontemsis, and neurotemsis. When you talk about the term temsis, it means a true cut, because neuropraxia, it's like a shock for the nerve, where the nerve is intact, but the electrical conduction is affected, and the myelin sheath integrity is preserved, and there is a full recovery without any intervention. You will do autonomic function, which will be preserved, while the Valerian degeneration doesn't occur as well. We all know that the Valerian degeneration is the axon degeneration distal to the site of the injury to start the healing of the nerve injury. While the axontemsis, there is a true cut for the axon, where the axon is damaged and the myelin sheath is preserved. The connective tissue framework is not affected, by the way, and there will be a Valerian degeneration occur, but there is no intervention for the axontemsis because the epineurium will be intact. We all know that there are 3 sheaths for the nerve: the epi, peri, endo. The epineurium, perineurium, and inneurium. The epineurium is the outer layer of the nerve. If it's cut, if it's injured, this is neurotemsis. because this will require a repair. There is a disruption of the axon myelin sheath surrounding connective tissue, and Valerian degeneration occur, and a surgical intervention will be needed for the neurotensis to be repaired. The nerve repair required neuronal repair by microsurgery team. The microsurgery team or the plastic team will do a neuronal repair which may only occur physiologically where the nerve are in direct contact. Where a large defect is present, the process of nerve regeneration is hampered and there is no healing power can occur by itself. So a surgical repair will be required. How to repair the nerve? Do you remember the preoperative or the surgical technique? We talked about the nerve repair can be repaired via a Prolene suture, and here we will choose a very fine type of Prolene suture like 8-0, and of course it will be around tapered, not cutting because it will cut through the nerve. So we choose a very fine microscopic suture like the Prolene 8-0 to be used, and it will be round to be fine over the epineurium, and there is no tension must be on the nerve, and if there is a gap found you can use a nerve conduit which is synthetic or biological, and this is very expensive, or you can use a sural nerve if you can remember, which is behind the lateral malleolus. This is a sural nerve with a short saphenous, the short is sural, while the long saphenous is with the saphenous vein. So take care, the sural nerve is very common to be used as a nerve graft for any gapping nerve, and the repair will take care after that by 1 millimeter per day. And of course here, after conducting the nerve, the Valerian degeneration can occur, where the axon degeneration distal to the site of injury will occur, and the process that occur when the nerve is cut or crushed and typically begin 24 to 36 hours following the injury or following the neuronal repair, and the distal axon remains excitable up to until this time. Axons are excitable prior to the degeneration occur, and the myelin sheath degenerate, and the phagocytosis by tissue macrophages will occur as well, and eventually the regeneration of the nerve may occur, although the recovery will depend on the extent of the manner of the injury. So roughly at the wrist, the area, the distance from the wrist to the distal phalanx is about 20 centimeters. So it will take 200 days to reach the very distal end of the fingertip after a median nerve injury at the wrist. This is the applied anatomy and applied pathology regarding the information we told you about the nerve injury. And by the way, any open cut injury must be explored. If it's closed injury and you sense that the patient has a nerve injury but there is no open wound, don't explore and do a nerve conduction test, EMG, after 3 weeks to know whether there is a neuropraxia or a true neurotensis required repair. But if you explore the nerve after an open injury and found it neuropraxia, there is no tension. You have to explore this. But it's most likely with the open injury to be neurotensis, and less likely to be neuropraxia with the open injury. However, I have faced many cases with neuropraxia in open injury. Take care. And in case you didn't take care of the nerve repair, take care that eventually the regeneration of the nerve will occur with recovery. But how does this happen? We all said that there is a Valerian degeneration. What we mean by Valerian degeneration, you will find that the myelin sheath degenerate and phagocytosis by the macrophages. This is the trick, and this is the question will be asked in the exam. So the exam will ask you about the rate, 1 millimeter per day is the healing, and will ask you about the process of the nerve healing. It's named Valerian degeneration. He will ask you, is it neurotensis, axontemesis, or neuropraxia, and the difference between them. We all agree that according to the Sunderland classification, the neuropraxia is where there is a compression or a shock for the nerve. There is no need for repair, while axontemesis might not require any repair because the neurolemmal sheath will be intact, but the axon will be affected, while in neurotensis there is a disruption of the axon, myelin sheath, and surrounding connective tissue and will require repair. Hope this made it simple. Of course, after any nerve repair, it will require splintage. Take care. Splintage to save the tension over the nerve. There is no nerve can withstand any tension. And again, we use a polyproline, very fine suture, round tapered, to be kept this nerve repair. Hope this made it clear. These great surgeons, we all know that the macrophage and neutrophil have an upregulation of the phagocytic cell surface receptor in these circumstances, where the process mediated by the pro-inflammatory cytokines, and these cells then engulf the microorganism. So what is the phagocytosis? Phagocytosis, when you remember phagocytosis, remember eating. And the first step in phagocytosis will be the opsonization, like putting salt over your food to make it tasty and eat it. That's what is the first step to eat a tasty meal, and that's what the macrophage does for phagocytosis. Phagocytosis is the ingestion of the pathogen or foreign material by the cell. And the first step is opsonization, whereby the organism is coated by the antibody. And the second step will be adhesion to the cell surface. And the third step will be the pseudopodial extension to form a phagocytic vacuole. It's like a dance towards the microorganism to eat it. And again, and lastly but not least, the lysozyme and lysosome fuses with the vacuole and degrade the content. So opsonization will facilitate the phagocytosis, and the microorganism become coated with the antibody like the C3b and 13 acute phase protein, and voila, the macrophage and neutrophil can eat a happily ever after meal by phagocytosis. So now it's clear that to understand the healing process, we have to understand the inflammation. And inflammation, we have acute inflammation and chronic inflammation. What is the inflammation? We all understand it, but what does it mean definitionally? The definition of inflammation is the reaction of the tissue element towards an injury, where there is a vascular change occur resulting in the generation of a protein which exudate. So long as the injury doesn't totally destroy the existing tissue architecture, the episode may resolve with restoration of the original tissue architecture. So there are three inflammation phases within the acute inflammation. We have the change in the blood vessel and flow, where there is a flush, flare, and wheal, and the fluid exudate and the cellular exudate. Those are the three phases of acute inflammation. Don't confuse the phases of inflammation with the healing process, where you have, the inflammation is one of the healing process steps. So inflammation, proliferation, and maturation. Take care. While in inflammation itself, the three phases are the changes in the blood vessel and flow, and the fluid exudate, and the cellular exudate. Take care. So the neutrophils are then transported to the tissue via the margination, not migrations, it's margination, and pavementing and immigration. So at first there is a margination of the neutrophil to the peripheral plasmatic vessel, and the pavementing then is adhesion of the neutrophil to the endothelial cell. At last there will be an immigration, where the neutrophil passes between the endothelial cell to the tissue. The vascular stages that happen within the acute inflammation. There is a vasodilatation occur and persist through the inflammatory phase, and the inflammatory cell exit the circulation at the site of the injury, and the equilibrium that balances Starling forces within the capillary beds. I know many surgeons will skip this point and forward this record along when they hear the Starling forces and this whole focus for them. But thank God the question about this point is not much in the exam. So the main point we want to be agreed on that the vascular changes mainly will be a vasodilatation through the inflammatory phase, and the inflammatory cell exits circulation at the site of the injury, and the high fibrinogen content to the fluid may form a fibrin clot. This has a several important immunomodulatory function, and the sequelae will be resolution, organization, supportation, and progression to the chronic inflammation. So, regarding the chronic inflammation may occur as secondary to the acute inflammation. In most cases, the chronic inflammation occurs as a primary process. These may be broadly viewed as being one of the three main processes: persisting infection with certain organism or prolonged exposure to a non-biodegradable substance like the silica or suture material or inflammatory process, and autoimmune condition involving antibody formed against the host antigen. So what is the main difference between the acute and chronic inflammation? The acute inflammation, there is a change in the existing vascular structure and increased permeability of the endothelial cell, while in chronic inflammation there is angiogenesis and predomination of this angiogenesis. While in acute inflammation there will be infiltration by neutrophil, while in chronic inflammation there will be macrophage, plasma cell, lymphocyte predominate. So neutrophil in the acute, while in the chronic will be the major macrophage and the plasma cell as well as the lymphocyte predomination. The chronic inflammation healing by fibrosis is the main result, while in acute inflammation the process resolution by the suppuration or complete resolution or unfortunate abscess formation or progression to a chronic inflammation, or even healed by fibrosis. So the question in the exam will ask you about the main cell in the acute inflammation. It will be the neutrophil, while the main cell in the chronic inflammation will be the macrophage. The end result of the chronic inflammation might be only fibrosis, while the acute inflammation might heal at all, complete resolution or suppuration or abscess formation, or even progress to a chronic inflammation. But the trick in the exam will be as well in the granuloma. The granuloma inflammation. A granuloma consists of microscopic aggregation of macrophage. So it's type of chronic inflammation with epithelial type arrangement, which is called epithelioid. So the epithelioid is aggregation of epithelial type arrangement of the macrophage. And the large giant cell may be found at the periphery of the granuloma. What granuloma do you know? So the giant cell, again, what is the giant cell? A giant cell is mass formed by the union of several types of cells, but commonly comprised of macrophage. A very common trick in the exam will be the least likely to occur. Don't fall in this trap. The least likely to occur is a very common trap. So read the last line of the question carefully and read what it asks you for. It's asking you to the commonest or the least likely, to the most likely or the least likely. A very famous question about an inflammatory process and asking you what changes could be the least likely to occur. Is it axillary lymphadenopathy or leukopenia or tenderness or mild pyrexia or local formation of yellow pus? Of course, all of those, the axillary lymph node and tenderness, mild pyrexia, local formation can occur with the inflammation, but there will be a leukocytosis, not leukopenia. So the least likely to occur is leukopenia. It's leukocytosis, not leukopenia. If you are not familiar with leukopenia and leukocytosis is high white blood cells and leukopenia is low white blood cells. With inflammation, there will be a high white blood cells. Dear great surgeon, there is a very direct common question that might trap you. Is the acute inflammation mediated by the free radicals? Of course not. The acute inflammation is not mediated by the free radicals. The chemical mediator facilitates the spread of inflammation into normal tissue. And the chemical mediators include the lysosomal compound and chemokines such as serotonin, histamine, which are released by platelets and mast cells. Other enzymes that cascade producing of the inflammatory mediator will be including the complement, kinase, coagulation, and the fibrinolytic system. So again, histamine, prostaglandin, leukotriene, serotonin are all inflammatory mediators, but the free radicals, even from the epidermal injury, is not mediating the acute inflammatory reaction. These great surgeons, there are common record questions regarding the neutrophil polymorph. Take care that the neutrophil, we all agree that they are the main cells for the acute inflammation, which is important action against the gram-negative and the gram-positive bacteria. and the appearance of segmented nucleus and granulated cytoplasm, and they have a lifespan of 1 to 3 days, shorter when they are consumed during aseptic process, though 9 hours is not unusual, while the main lifespan is from 1 to 3 days unless there is a severe septic process. And the action of the neutrophil include the movement, opsonization, microorganism phagocytosis, intracellular killing of the microorganism by the aerobic production of the hydrogen peroxide, and anaerobe mechanism. Take care. The AIDS associated with the T cell deficiency and the neutrophil disorder include chronic granulomatous disease, even it's rare but can occur. So the question is, neutrophil disorder can cause a chronic granulomatous disease? I know you are tricked all because the neutrophil is the main cell for the acute inflammation, unlike the macrophage, plasma cell, lymphocyte is the main cell for chronic inflammation. And we all said that the granuloma and the granuloma inflammation is all about the macrophages. But take care. The mediators of the granuloma growth factor released by activation of the macrophage include the agent interferon, fibroblast growth factor. Some of these are interferon may have systemic feature resulting in systemic symptoms and all of these, but take care that the neutrophil itself can cause a chronic granulomatous disease because acute inflammation can proceed into chronic inflammation. So indirectly, the neutrophil disorder can cause a chronic granulomatous disease. It's a very tricky, cheap question, in fact. These great surgeons, some questions in the exam, it's not about understanding, it's all about memorization. This is medicine. Welcome to medical school. So, regarding the granuloma disease, what can cause granulomatous disease? Of course, the allopurinol for the gout, and the sulfonamide, and the beryllium, and the Wagner granulomatosis. All of those can cause granulomatous disease. But take care, the amiodarone doesn't cause a granulomatous disease. And of course, the TB and sarcoidosis are very common causes for granuloma formation. And a very long question will be in the exam about a very big scenario, and the end result we will be asking about the histological feature that might be with the sarcoidosis. He might mention the sarcoidosis itself or might mention the disease granuloma formation within the lung. So what are the histological features that more likely to be associated with sarcoidosis? Take care. The most likely lymph node, if sarcoidosis is present, will be the asteroid bodies. The asteroid bodies are often found in the granulomatous individual with sarcoidosis, unlike the granuloma, which is associated with the tuberculosis, will be associated with extensive necrosis. Caseous necrosis with the TB, while asteroid bodies with the sarcoidosis. These great surgeons take care again. The macroscopic features of the chronic inflammation is ulcer, fibrosis, granulomatous formation, and by the way, again, it's commonly occur as a primary event. It doesn't have to have an acute inflammatory process to proceed as a chronic inflammation. There are many chronic inflammations start of chronic from the start. And of course, appendicitis is a feature of acute inflammation, while something like TB and sarcoidosis are chronic inflammations. Now I want you to be familiar with the pathological calcification. We have dystrophic calcification and metastatic calcification. The dystrophic calcification, there is a deposition of calcium deposit within the tissue that have undergone degeneration damage for a disease in presence of normal serum calcium level. While the metastatic calcification, there will be a deposition of calcium deposit in the tissue that are otherwise normal in the presence of increased serum calcium level. There is a drainage of the calcium and it will be high because the cancer is draining for more. So a very famous scenario for the dystrophic calcification will be the breast implant, which often becomes surrounded by pseudocapsule, and this may be secondary then subjected to the process of the dystrophic calcification. To understand the healing process of anything, you have to start with the phases of the wound healing. The phases of the wound healing and the surgical wound are either incisional, excisional, or whatever, clean or clean contaminated, or even dirty. They have stages to wound healing, and broadly similar to the contributors, will vary according to the wound type itself. And the main stage of any wound healing that will come in your exam about hemostasis, inflammation, regeneration, and modeling. Remember, the inflammation is a part of the wound healing. So hemostasis, inflammation, regeneration, remodeling, those are the 4 phases of the wound healing. Let's start with the hemostasis, where there is an initial vasospasm in adjacent vessels and the platelet block formation and regeneration and generation of the fiber-rich clot. Temporary blood will be the main thing happen in the hemostatic stasis, and the main cell driving all of this will be the erythrocytes, the red blood cells, and the time frame will be within seconds to minutes. While the inflammatory phase of the wound healing, the main cell driver here will be the neutrophil, fibroblast, and macrophages. The macrophages and neutrophil will be cooperating in the inflammatory phase, and this phase will be taking the very first few days, where the neutrophil migrate into the wound and function impaired in diabetes, by the way, regarding the neutrophil migration, and the growth factor will be released, including the basic fibroblast growth factor and the vascular endothelial growth factor, and the fibroblast will be replicating with the adjacent matrix and migrate into the wound. And here, the macrophage, the fibroblast, coupled matrix, regeneration, and the clot substitution. I want to stress in the inflammatory phase that we have the neutrophil and the macrophage, and I want to stress that in the inflammatory phase we have the fibroblast, because in the very next 2 phases you will wonder that the fibroblast will change to his older brother, the myofibroblast. The myofibroblast will be the driver in the remodeling phase, and the fibroblast itself will be the driving cell within the regenerative phase. So the hemostasis with the erythrocyte, while the inflammatory phase with the neutrophil and macrophage, and the regenerative phase will be the fibroblast, where the platelets drive the growth factor, transforming growth factor, stimulate the fibroblast and the epithelial cell, and the fibroblast produce a collagen network. Who doesn't need collagen for regeneration? You hear all the ladies ask for the collagen. Thanks for the fibroblast. And here, a new angiogenesis will be formed, a new blood vessel will be formed, and won't resemble the granulation tissue will be formed. This is the regeneration phase by the fibroblast. Thank you, fibroblast. This phase will take few weeks, while the remodeling phase will be lifelong, starting from the 6 weeks to 1 year, and it will be driven by the myofibroblast. And this is a common recurrent question: what drives the remodeling phase after 6 weeks? You will ask you about the remodeling phase itself, or ask you about the myofibroblast itself, or ask you about the driving cell after healing, after the regenerative phase. He will tell you this wound is 6 weeks old. So what is driving the changes in the cell now and the healing process? This is a remodeling phase. This is a myofibroblast. The longest phase of the healing process will be the remodeling phase that might last up to 1 year or longer. During this phase, the fibroblast become mature and differentiated and become the myofibroblast, and these facilitate the wound contraction, and the collagen fiber are remodeled. There will be a new addition of the collagen remodeling, and the microvessel regress, leaving a pale scar. So the scar is the end result of any other wound. Any wound end stage will be a scar. But regarding the scar formation and the problems with the scar, there are many factors affecting the scar formation, and this is the next thing we will talk about. Again, take care from the terms vasculogenesis and angiogenesis. Vasculogenesis is a new vessel developing in situ from existing mesenchyme, and the angiogenesis is a vessel developed from the sprouting of pre-existing artery. So the vasculogenesis is from the mesenchyme. Angiogenesis is from the pre-existing arteries. So fibroblasts, we all know and agree that they are important cell in healing wound, and they typically proliferate in the early phase of wound healing, in the regenerative phase, not in the remodeling. They release the matrix metalloprotein, and these facilitate in the remodeling of the matrix within the healing wound with the myofibroblast, while the necrosis in healing wound would be unusual because the wound tend to show clinical evidence of angiogenesis by this time. So necrosis of fibroblast is not logic to be found when we are aiming for angiogenesis, when we are aiming for regeneration. And remember when we talked about the factors that affecting the wound healing? Take care again. There are general and local. General within the whole body of this patient, and local regarding the local wound we are talking about. So if the patient have a chronic disease like diabetes, hypertension, or cardiac, or even liver disease, this can impair this healing. If he had malnutrition or taking drugs like steroids, chemotherapy, lacking vitamin C or lacking vitamin A, lacking zinc, magnesium, or manganese, or even he has a neoplasia, he is cancerous patient, take care. This can interfere with the healing power. This is a general cause. And the hypoxia, this can cause impairment of wound healing. Low temperature can cause impairment of wound healing. Liver jaundice and sclerosis and autoimmune disease can cause general causes for affecting the wound healing and impair it. While take care regarding the local causes like infection, foreign body, or tissue necrosis or under tension, all of those can affect the local wound to be not healing properly. Take care. Dear great surgeon, take care. A very common recurrent question is a trap about wound healing regarding the chronic inflammation from the beginning. If the wound healing contains features of chronic inflammation from the beginning, no, of course, because you might confuse yourself by the macrophage being a part of the chronic inflammation and the neutrophil being a part of the acute inflammation. But take care, in the inflammatory phase of the wound, it's not talking about the acute inflammation or the chronic inflammation. We are talking here about the inflammatory phase of the wound healing, acute inflammation, caring at the wound. Inflammatory process is a part of the wound healing. We are not talking about a chronic wound at all, although the wound contains macrophage and the process of angiogenesis occur. This typically take time to occur and they are not present in the mature wound. So it's not about a chronic inflammation at all. It's about scar formation. Scar formation means everything has ended already. While in sarcoidosis, in TB, we are talking about chronic ongoing disease inflammation. While in wound healing, we are talking about a scar formation where everything has been already resolved. So don't confuse yourself. The macrophage here is doing his job as a soldier and finish his job and become a fibroblast, and the fibroblast become a myofibroblast in the remodeling phase towards scar formation, not towards a chronic inflammation at all. Chronic inflammation like TB, sarcoidosis, or whatever. Regarding the wound healing and the scar formation, take care. There are some problems within the scar. But before we know about the scar, let's get familiar with the closure. If there is a wound and we want to make sure this wound heals probably with the least scar, better to be done with a primary closure, or even at least delayed primary closure to give it the best chance for a better cosmetic result. And by the way, the dermis, not the epidermis, is responsible for the scar formation. The more derms adherent to each other, the less scar. But if you take care of the epidermis, it will be loose scar and will gap, and you will see through the epidermis until there is a gap below it, the subcutaneous tissue as a transparent media, and this is the scar. But if you adhere the dermis over each other, the epidermis will creep over the dermis and this scar will be rarely seen. So the trick regarding the scar is the dermis. So better to do a primary closure if the wound is clean, or you can do it clearly, like the wound in the scalp. If it's dirty, please go wash it clearly. It has a good vascularity, you can go for it. But in a wound within the foot, go for it to debride and take a secondary look to see if it can be taken with delayed primary closure. Or this patient, high risk diabetic patient, we will take a frequent dressing and secondary closure, secondary intention be done. So the primary intention you have to close, the secondary intention when there is no need to close this wound due to many local factors affecting this patient wound criteria. So in the delayed primary closure, the anatomical precise closure that is delayed for a few days but before granulation tissue become microscopically evident. In the secondary closure refers to either spontaneous closure by secondary intention or to a surgical closure after granulation tissue has formed with a graft, for example. Regarding the hypertrophic scarring and the scar formation, take care. If a wound takes time to heal, it will eventually cause a problem. And the hypertrophic scar is the least of them. Excessive amount of collagen within the scar and nodule may be present histologically, containing randomly arranged fibrils. Within these parallel fibrils on the surface, the tissue itself is confined to the extent of the wound itself, and is usually the result of a full thickness dermal injury. Again, it's all about the dermis. They might go to develop contracture. You can manage them with a compression garment and silicone sheeting. This is the trick with hypertrophic scar and will do the trick. Regarding the keloid scar, they are more extensive amount of collagen within the scar, and they have genetic predisposition and more common with the dark skin. Typically, a keloid scar will pass beyond the boundaries of the original injury, and they don't contain nodules. Unlike the hypertrophic scar, they may occur following even trivial injury. They don't regress over time and may recur following removal. It has a very high recurrence rate, unfortunately. It's like a tumor, but it's not a tumor. It's a very devastating, awful looking scar. Image of a keloid, note the extension beyond the boundaries of the original incision, and take care. The steroids, immunosuppressive agent, and antineoplastic drugs can cause it. And the keloid scar are very common to occur over a burn. And by the way, after the burn, if you didn't have a keloid scar and have a non-healing ulcer, we are talking here about a marginal ulcer which is cancerous. So burn must be taken off. Take care of the burn and manage it well. And the better you heal it well and the better you manage it, the less complication and less morbidity. We are here as a surgeons to serve the patient, lifestyle and dignity. Again, to sum up again regarding the hypertrophic scar and the keloid, the hypertrophic scar doesn't exceed beyond the wound margin, while the keloid will exceed beyond the wound margin. The hypertrophic scar, if resistant to the compression garment and the silicone sheeting, you can do excision and with low recurrence rate, while the keloid scarring have a genetic predisposition as well as dark skin predisposition and resist the surgical management. If you insist to take it surgically, please take intralesional, because this might cheat the brain, because the brain already knows that there is a scar here. So leave a small margin of the keloid while excision of this keloid to trick the brain as if there is a keloid already existing here. So the surgical option for the keloid is not good at all and recurrence rate is high. And of course you will treat it as well with a compression garment as well as a silicone sheeting and the steroid injection. Take care. Hope this made it clear regarding the hypertrophic scarring and the keloid. And by the way, regarding the keloid, always tell your patient if he has a genetic predisposition or he has a skin liable to formation of the keloid, it's nobody's fault. It's not a surgeon fault. It's not his fault. It's his body nature, and we will deal it together. Together we can work on it. We are on the same team.